Okay, so next up, we have a talk regarding cancer. Cancer is the leading cause of death in Singapore. And although cancers are in fact curable if treated early, in most cases, they do not show any symptoms until they are advanced. Dr. Melvin is here today to share the importance of screening and to help you decide if you should go for screening. Dr. Melvin is a consultant general surgeon and medical director of the Pan-Asia Surgical Group in Mount Elizabeth Orchard Hospital, Mount Elizabeth Novena Hospital, and Parkway East Hospital. He's a general surgeon with a subspecialty expertise in gastrointestinal surgery, therapeutic endoscopy, including ERCP, and advanced laparoscopic surgery. He's currently also a clinical teacher with the Duke NUS Graduate Medical School. So let's put our hands together to welcome Dr. Melvin.
Thank you, everyone. It's a great pleasure to be here to share with you some medical information about cancer screening. I think this is a very important topic because hopefully at the end of this talk, you will realize it may be something that can actually save your life. Okay, so we are talking something that's quite general today, all types of cancer screening, which ones you should go for and which ones you should not waste your money on. But to introduce myself, I'm a gastrointestinal surgeon, so I deal mainly with stomach problems, abdominal surgery, colon problems. So I would talk a little bit more about the things I know best, okay? Okay, why do we want to talk about cancer? You know, it's a frightening topic, not a happy topic. But cancer is important because cancer is actually the main cause of death in Singapore now. Okay, in the old days, maybe like 50 years ago, a lot of the people die from infectious diseases, tuberculosis, things like that, and maternal mortalities and all that, you know, childbirth deaths and all that. But now, as medical advances, due to medical advances, all these things are becoming less and less. Infectious diseases and all that we can control with drugs, antibiotics, and all that. And the last frontier is cancer, because cancer occurs more frequently as we age. Because our cells grow older, they are more prone to degeneration and cancer change. Okay, so cancer is now the #1 killer in Singapore. #2 is heart disease. Okay, but cancer is actually #1. If you look to your left and your right, 1 in 3 of us in this room actually will have cancer in our lifetime. Okay, that's quite a frightening statistic, right? And this is Singapore's statistic, 1 in 3. And 1 in 4 of us in Singapore will die from cancer. Okay? But the good news, although this is a bad statistic, the good news is actually 40% of cancers can actually be prevented. And if you catch cancers at an early stage, almost all cancers can be cured. If you talk about cancer in general, anywhere, lung cancer, you know, nose cancer, colon cancer, as long as you diagnose it at an early stage, stage 1 or even stage 2, there's a very, very good chance of cure. Okay, so screening is about trying to detect cancer at an early stage. Okay, or even better still, screening should also help us to prevent cancer by treating cancer at the pre-cancer stage. That means even before it becomes a cancer. So removing the pre-cancer can actually prevent the cancer. We talk about screening all the time, you know, like colon cancer screening and all that, and you say, oh, dad, you know, maybe your dad is 60s, he's in his 60s or 50s or whatever. You say, oh, you should go for screening for your colon cancer. You know, the government always talk about screening nowadays. And he says, no, I got no symptoms. Why should I go for screening? I eat well, I eat very healthy, you know, I have a good lifestyle, and I got no family history of cancer, you know, and I have no symptoms. Why should I go for screening? But precisely screening is that. Screening is testing you for cancer even though you have no symptoms. That means routinely do the check based on the criteria which we will talk about in a while. Okay, so we need to define who should go for cancer screening, how to do the cancer screening, and when you should do the screening. Okay, and we also want to introduce a few terms to you. What is population screening, individual screening, and high-risk screening? I want to introduce these terms because it helps you to understand what the newspapers are talking about. Okay, population screening means a statement that is released by the ministry or the health minister that applies to everybody. So if I'm the Minister of Health today and I want to talk about colon cancer screening, I'll say everyone should go for a stool test, you know. Okay, that's something for the population. Because as a health minister, I want something that's easy to do, cheap, you know, will not burden my finances of the ministry so much. Okay, so when you talk about population screening, it's some type of screening that is good to do, but may not be so accurate, but still good to do. Okay? Now, individual screening is a bit different. Individual screening is like me and you know, talking, you know, friend, you should go for screening, but you know, you should choose the best, right? You shouldn't do just the population that is easy to do and cheap. You want the best, the most accurate. So that's individual. So today I'm talking to you not as a health minister, I'm talking to you as a doctor. I would want to give you the best advice for you. So that's individual screening, okay? And high-risk screening is a bit different. High-risk screening, you don't belong to the normal criteria. High-risk means you have a strong family history of cancer, or you have some other condition in the, you know, that you already have that predispose you to cancer. For example, people with ulcerative colitis, inflammatory bowel condition. If they have that, they have a high risk of colon cancer. So they belong to a high-risk category. Their criteria for screening is different from you and me sitting here. Okay, so understanding these terms will help you to understand why we say certain things in the media, all right? So in order for cancer to be screened, we don't talk about screening for all types of cancers. Even though our Prime Minister had lymphoma, we don't ask you all to go for screening for lymphoma. Why? Because lymphoma is not common at all, right? Even though you know it's something that was in the news, it doesn't warrant screening because you need to check so many people before you can find one case, so it's not worthwhile. So you want to choose cancer for screening, you choose something that is common, and that cancer must be detectable at the early stage. If you can't detect it at the early stage, no point, right? Because you can't cure anyway. And if you detect it at the early stage, it must be treatable and curable. Okay, so those are some of the criteria for screening. How do we do the tests for screening? The test that we choose must be relatively sensitive. Sensitive is a medical term which means that it is quite accurate in picking up. Okay, so no point doing a test that is not sensitive at all. You know, even though you have cancer, the test doesn't show up as positive. Okay, so that kind of screening test is no good. So it must be sensitive for picking up. It must be something that's quite safe, acceptable to do, easy to do, not too expensive, and easily available. Okay, but of course you will realize that for an ideal cancer screening test, none of our available tests would fulfill all those criteria. So it's a compromise between accuracy, cost, and invasiveness and availability. Okay. Now, which cancers should we screen for? Hey, you all should know this, $5 to go for cancer screening. Okay, so this is from the ministry. If you are above the age of 25, they recommend doing your cervical screening. Above the age of 40, you should check for chronic illness and cervical screening, $5 only. And above the age of 50, check for colorectal cancer, breast cancer, and chronic illness, $5 only. Pioneer generation, $0, free. It's quite good, huh? So you all should go for. But of course, when you do these, all these mass screening, these are called mass screening. They will pick something that is not so expensive, but still fairly good to do. But if that test turned out to be positive, you might have to go for further testing. Okay? But we want to talk a bit more about which cancers we should screen for today. We should look at which are the common cancers, right? So the commonest cancer in Singapore now, in males, maybe we should flash the next slide for this one. Yeah, flash. Okay, this one is female. So sitting on this side is females. Sitting on this side is males. So we talk about males first. The commonest cancer is actually colon cancer now. It used to be stomach cancer for a very long time. Then it was lung cancer because of smoking. And now colon cancer is #1 because of our lifestyle. The food we eat, most of us are getting obese, lack of exercise. All these are risk factors for getting colon cancer. So colon cancer is #1 now for males. And in females, it's #2. Lung cancer is also very common. In males, prostate cancer, liver cancer, stomach cancer. The rest are less and less common. So these are the ones we should pay attention to. In females, of course, you get all the female type cancers, breast cancer. Corpus uterine means womb cancer, uterine cancer, endometrial cancer, they mean the same thing. Ovarian cancers, okay? Cervical cancer, that means cancer of the cervix. So these are some of the cancers we will talk a little bit more about today. But I want to talk especially more about colon cancer because not because it's something that I do, but because it is number 1 and number 2 respectively. Okay, let's go to the next slide. Look at colon cancer in Singapore. This is the incidence in red is male, orange is female. This is Singapore. Look at our incidence. It's chasing what the Americans are having. Okay, Americans, colon cancer is number 1 and number 2 also. So our incidence is from a low incidence now, over the years, is becoming more and more frequent. Okay? In many years ago, it used to be around this kind of incidence. So you look at less developed countries like Laos, Mongolia, Sri Lanka, and all that. Colon cancer is actually not very, very common. Huh? Okay? It's not very, very common. So that's quite interesting, this epidemiology. Look at stomach cancer. Stomach cancer in Singapore used to be very high, and now it's dropped in incidence. You look at America, stomach cancer is actually very, very rare, not common at all. Okay, so that's quite interesting. Stomach cancer unusually is quite high incidence in Japan and Korea. I think it's partly the diet and the genes as well. So, which cancers should we screen for? I think these are the important ones and which are the ones that we will talk about more today. Colon cancer, and together with colon cancer, we will discuss stomach and liver cancer as well as a package. We'll talk a little bit on lung cancer, for the males, prostate cancer, and the women's cancer, breast, cervical, ovarian, and endometrial cancer. We'll touch a bit more about these, but I will talk mainly about colon cancer today, okay? This is the colon. The colon starts on our right side here, and it curves round all the way to the left side, okay, and then it comes down. So the stomach is here, the stomach brings the food down, the small intestine, and it goes to the colon, which is the large intestine, right here. That's also where the appendix is. Okay, appendix cancer you can get also, but appendix cancer is very, very extremely rare. Okay, so colon, it goes up. The food that you eat comes to the right side of the colon. It's more like a liquidy kind of mixture after eating and digestion has taken place. So the colon absorbs the water from this mixture and converts this mixture, this liquid mixture, into solid stools. It passes all the way to the left side, and the stools are stored in the rectum before you pass it out. So colon and rectum, colorectal cancer, or large intestine or large bowel cancer, all mean the same thing, okay? Which are the commonest areas where colon or colorectal cancer happens? Usually here and on the left side. But right side cancers can happen as well. So usually people get rectal cancer, colon cancer around this area, okay? What are the symptoms do you think you will get if you develop a cancer in the colon? In the early stage, where the cancer is very small, probably no symptom at all. So a small cancer, stage 1, stage 2, sometimes even stage 3, no symptom at all. But when it becomes too big and too large, if you can imagine a cancer sitting here, right here where your anus is, you might start to feel a symptom of discomfort in your anus. Like after you pass motion, oh, still got something there, you know. Feel like there's something there all the time. You pass nothing, or maybe a little bit of stools, or a little bit of mucus you pass out, or a little bit of blood you pass out, but not significant passage of stools. And after you pass out, still something there. Maybe it's a tumor that is stuck here in the low rectum, or this tumor might start to bleed. So when you pass motion, you find there's some blood mixed within the stools. Or after you pass motion, when you wipe, you find there's some blood the paper that you clean it from. Okay, so bleeding when you pass motion is never normal. Most of the time, bleeding when you pass motion is due to benign problems like hemorrhoids or piles or fistulas and all that, but it's never normal. So when you have blood in your stools, you must see a doctor because it can be due to a tumor that's sitting here. Okay? Now, as the tumor gets bigger and bigger, it will also affect the size of the stools that you pass out. So from a nice big stools that you used to pass every day, now instead of passing motion every day, you find that every 2-3 days, then you can get a motion out, and the stools are getting smaller and smaller. Or some people say even like pellety, like rabbit stools. Doc, my stools are getting like rabbit, no? Rabbit stools, pellet, very hard to pass out, and many times a day, a little bit. It may be a sign of obstruction. Okay? So as the stools get bigger and bigger, you might find the tumor gets bigger and bigger, you might find a change in your bowel habits. So from a frequency of passing stools every day, now you find that it's becoming less and less frequent. Some people get more and more frequent. They even get diarrhea. Diarrhea cannot be a sign of obstruction, right? But it can actually be. Why? Because as the tumor gets bigger and bigger, the solid stools cannot pass through. Only the liquid parts can pass through. So you find that you keep getting these loose stools, diarrhea, your stools are not formed, and many, many times a day, but it actually is a sign of obstruction because the nice big solid parts cannot pass through. And as more and more obstructions takes place, you might find that you start to get discomfort or pain, abdominal discomfort, abdominal pain. So that's another sign of colon cancer. Okay? Now, imagine the cancer is not here now, but the cancer is on the right side. What symptoms do you think you will get on the right side? Remember, the stools here are not solid stools. It's the food residue that you get that has partially digested. It's this slimy thing. It's this watery thing. So it's very hard to get an obstruction, right? Because the stools are quite liquidy. So you might not get any symptom of obstruction at all. You might not even see blood in the stools because if the tumor bleeds here, by the time the blood passes to the left side, it changes color, so you wouldn't even notice blood in the stools at all. You might not even notice pain because there's no blockage until the very, very last part where the tumor is so big that it completely obstructs the system, what we call intestinal obstruction. Your tummy becomes very bloated, you start to vomit feculence, the feces instead of going down, you start to vomit feculent vomitus. This is a very late sign. So remember, tumors on the right side can be asymptomatic for a very long time until the final stage. Okay? So if you start to get vague discomfort or anything, or you suspect something, you should quickly see a doctor. Or better still, come for screening. Why? Because the aim of screening is to pick up tumors on the right side, left side, anywhere in the colon at an early stage, at a small stage, when they don't have any symptom at all. That is the time when we can cure you. Okay? Next slide. Okay, this is a very important slide because it is something we know very well and it's something that you need to understand how a colon cancer develops. Now, imagine this is the wall of the colon, right? The cancer always forms on the internal layer of the colon. Why? Because the cells in the internal layer of the colon are the cells that keep reproducing all the time because they are exposed to the feces and all that, right? So they keep reproducing more and more cells and then to replenish themselves. Okay, in this process of replenishment, sometimes an accident happens in the gene. An accident happens for no reason, okay? Our cells, our genes become older as they duplicate themselves to form new cells. Sometimes an accident happens. And this genetic accidents results in mutant genes, okay, mutant cells. So mutant cells containing mutant genes which start to form a colony of mutants of their own. Sometimes these mutants get bigger and bigger and they form a whole group of mutants, mutant colony, what we call super mutants. These super mutants keep on reproducing themselves at a high rate, rapid rate, and then they slowly form into what we call a polyp. So a polyp is something like this, a little fleshy growth. A polyp just means a little fleshy growth. Whereas the polyp gets bigger and more mutations take place, then the polyp becomes a cancer. Okay? Now, why do all these mutations take place? No reason, just accidents. As our cells get older, we're more and more prone to accidents. That's why most cancers start to occur at an older age. Most people start to get cancers around 50s, 60s, 70s. By the time you're 80s, 90s, the cancer risk is higher and higher. And all this is accident. So even if you live very healthy lifestyle, you eat very well, you have no family history of cancer, you can still get an accident, correct? Even when you cross the road and you're very, very careful, right? Something might still happen. You take the pedestrian crossing, wait for the green light, somebody can still knock you, right? So any accidents can happen to any one of us. So don't think that you are immune from cancers, even though you live a very healthy lifestyle. Okay? So what happens now when this polyp becomes bigger and becomes a cancer? The cancer cells have a propensity to invade. Cancer cells are mutants that are very aggressive. Now these cancer cells start to get deeper and deeper into the wall of the colon. And, okay, as the cancer cells get deeper into the wall, they invade into the blood vessels, and then they spread through the circulatory system, through the blood system, through the lymphatic system, and then they lodge themselves into other areas like the liver, the lungs, the bones, the brain, by which time you get what we call stage 4 cancer. Cancer that has progressed from the primary site in the colon to multiple sites in the body. Okay, stage 4 cancer is incurable. No matter what kind of therapy or chemotherapy you find, or immunotherapy, you will not be able to cure that cancer. Very, very unlikely. So we will not want you to be diagnosed at this stage, where it's stage 4. We want you to be diagnosed at the early stage, at stage 1 or stage 2, where removing the cancer has a very good chance of curing you. Or even better still, if we backtrack one slide, we try and diagnose you at the polyp stage. Is it possible? If we diagnose you at the polyp stage and remove the polyp, will that prevent the cancer? What do you think? Yeah, answer is yes. Okay, so doing a procedure to check for early cancer has the advantage of detecting polyps as well. And removing these polyps actually prevent colon cancers. 90% of colon cancers start as polyps. So 90% of colon cancers in Singapore, or every one of us, are preventable. Okay, so that's the important message that you should take home. And how long does it take from a polyp to become a cancer? Not 3 months, not 6 months. It takes 5 to 10 years for a polyp to form and slowly become a cancer. Therefore, you have a lot of time, a big window of opportunity to do colon checking and to remove these polyps. And once you remove these polyps and you are clean, your colon is clean, you are protected from colon cancer, 90% guarantee for 5 years. Okay? For the next 5 years, you're clean, right? So not bad, 5-year guarantee for colon cancer protection. Okay, so we'll talk more about that in a while. So let's go to the next slide. Okay, this is what a small polyp would look like, a small growth. Okay, so this is a benign thing, not cancerous, but pre-cancerous, because the cells in here are mutant cells. As they get more and more bigger and bigger, as the polyp becomes bigger and bigger, then more and more mutations may have taken place and may have become a cancer and this big polyp. But this big polyp is still curable, even if there's a cancer in the polyp. So when we do the scope and we find this, we will remove this. And if we find this, we will also remove this. And removing it with the scope actually will cure this cancer, this small early cancer. Okay? Not before it, but not once the cancer has invaded into the stalk, into the wall, then it's not curable anymore. Okay? So the aims of colon cancer screening are to detect colon cancers at the early and curable stage, and also to prevent cancers by detecting and removing these pre-cancerous polyps. In fact, colon cancer is the most preventable type of cancer. Okay, so when do we screen for colon cancers? Age is the most important criteria. Why? Because as our cells grow older, we're more and more prone to getting all these polyps. And from statistics, from studies, we all know now that polyps start to form for most of us, from the age of 40 or so, we start to form polyps. Okay, so by this statistic, we usually recommend from the age of 45 to 50, you should start doing your first colon screening. Our Ministry of Health recommends from the age of 50. If you talk to us as doctors, we say, be a bit more careful, 45, start to come. Okay? Okay, the reason why is when we tell you 45, usually people will procrastinate for 1 year, 2 years, 3 years before they really get off the butt to do it, right? But yeah, 45 now is our recommended guideline. But if you are high risk, let's say your brother had cancer, colon cancer, then you will also have a higher risk because your genes are more susceptible to all these kind of changes, and you might start to form polyp at an earlier age. Therefore, if you are the high-risk category, you've got a lot of cancer history in your family, then you should start from the age of 40, or even 10 years younger than the age of your relative with cancer. What do I mean by that? If your sister or your brother had cancer at, say, age 40, that means your sister had polyps when she was 30, right? So in fact, you should be doing yours at age 30. So 10 years before that close relative with cancer. So the younger the people with cancer, the more likely there is some genetic problem. Okay, that means there's some genetic risk involved. Okay, if an older person gets cancer, we say, I think it's probably an accident, this genetic accident because of his age. But a young person to get cancer, usually maybe the genes may be defective in the first place. So if you have many relatives in your family who are young people who are cancer, then suspect that it may be a genetic thing that runs in your family. So in fact, in this year, the American Society has updated their guidelines to say that screening should actually begin from age 45 for all of us at average risk. Okay, the reason being, now, new cases of colon cancer are occurring at increasing rate among younger adults. So we quite regularly see young people with colon cancer now. In the 30s, in the 40s, we see a fair number of them now. Therefore, we really actually want to really ask you to start doing colon cancer screening at age 45 rather than 50. Okay, how do we do colon cancer screening? If you're looking at the Ministry of Health, they will say, we give you a few options you can choose. And the options are stool test, you can do an X-ray, or you can do a scope, what we call colonoscopy. But if you look at the American College of Gastroenterology, they will say there's only one way to do colon cancer screening. You should go for a scope, colonoscopy. But our government usually a bit more flexible. They want to give you options. Hopefully you take the cheaper option, okay? Okay, but these are the ways. If you do a stool test, you should do a stool test every year. If you do a scope, it will protect you for 5 to 10 years. Of course, the government will say 10 years should be okay. But as doctors, we know 10 years may not be okay for everybody. So better 5 years, every 5 years. Or you can do an X-ray, what we call a barium enema. This is what a barium enema looks like. It is a very, very old test that we used to do when I was a medical student, kind of thing. Some of you might have gone for this, a barium enema test. A barium is this white paste that they shove up your backside. They put a tube into your backside. They pump in the barium, which is the white paste. They pump in a lot of air. Then they turn you upside down, left and right, and they take quite a few X-rays like these, hoping to find something. Here you can see a narrowing. The barium sort of trickles to a narrow area here. So there's a tumor here. Okay? But realize that you're looking at two-dimensional black and white photographs compared to what a scope is, which is high-definition video, real-time that we're doing. So you can imagine the quality of examination between a scope and a barium to be vastly, vastly different. A barium is quite good for detecting big cancers, but a small polyp, which is actually what we want to find, right? Small polyp is actually quite hard to detect. And if we find something there, a little spot there, not sure, is this a polyp? Then they call another radiologist. Maybe it's a piece of feces that's stuck there and a picture of it. In the end, they'll say, could be a polyp, better go for a scope. So in the end, you'll still end up with a scope. Okay, so if you ask me, you want to come for screening, colon cancer screening, forget about barium. Okay? Now, what is this stool test? This one died. Okay, a stool test is actually taking a little bit of your stool sample and testing it for what we call occult blood. Occult blood means blood in the stools that cannot be seen by you. Even if you look at it very closely, you will not be able to see any blood, but they may be microscopic traces of blood cells. That's what occult blood is. And the reason behind doing this stool test is that we think that if you have a cancer in there, in your colon, or you have a very big polyp, it may bleed into the stools. And doing a stool test for this blood, traces of blood in the stools, may be useful for helping us to detect people who have early cancer or big polyps. Okay, but you will realize the limitation of doing this test. It depends on the piece of sample of stool that you take. If that sample of stool did not contain the blood cell, it will be negative. So there is a fairly high false negative. Okay, so you might do the stool test, and it's negative, you think you're happy, no, but actually you might have a cancer still. Okay, so it's not that accurate. So if you ask me, a stool test is very good for population mass screening, but it's not very good as individual screening. It's very good for, let's say I come for a lecture and say, hey, everybody, when you go out the door, take one stool kit and go back home and do. It's very easy. It's very easy to do, very cheap, and it's actually, it's useful. Okay, but it's not that accurate, you must remember. So if you want to do a stool test, you must do the stool test a few times, and you must do it every year. So when you do the stool test a few times, don't just take the same sample. Today, take one sample, tomorrow, take one sample. And the day after, take one sample. Okay, so you have increases your accuracy. And if it's all negative, repeat the test next year. So you must do it yearly, not every 5 years or every 10 years. Okay? And some stool tests will also test blood from animals. So these tests are not so good, what we call the guaiac stool test. So if you have a big piece of steak the last night with quite rare, a lot of blood cells, you might actually test positive because you have a lot of cow blood in your system. It's true. That's what we call false positive. And then the stool become positive, then you get very, very worried. You think you have cancer. Okay? And you go for further testing, you find actually nothing wrong. So if you want to do a stool test, go for what we call the FIT test, immuno testing. That one only recognizes human blood. Okay, so unless you've eaten a steak from a human the night before, it will not test positive. Okay? So stool tests also got different ones. Okay, we talked about barium already, so now we talk about colonoscopy. To me, colonoscopy is the gold standard. Okay? Why? Because it's the highest sensitivity. You do it once, you don't have to do 2-3 times. You do it once, and if you do it once, it's negative, it will protect you for the next 5 years at least. Okay? And it's also the only test that allows us to remove polyps if we detect them. So straight away, if we find this polyp, we will remove it straight away, and that actually prevents cancer. So it's the only screening test that also prevents cancer. This is what, is it running? No, it's not. Strange. Okay. Okay, the video isn't running, but I'm supposed to show you the video of the colonoscopy. You will realize that it's a real-time, high-definition video. If we find something here that's suspicious, we can wash it, we can poke it. If we think it's a polyp, we can remove it straight away. It's a simple procedure that takes about 20 minutes to do. You don't even have to stay in hospital. You can do it as an outpatient. Come in the morning, we give you a little injection to sleep for about 20 minutes or so. Sedation, not general anesthesia. You don't need general anesthesia. So it's very safe. Just a sleeping pill that we inject into your blood to knock you off very quickly. At the end of the procedure, you wake up, you have your biscuit and your Milo, you can go home. Okay? It's a very simple procedure. It's very safe. It's very comfortable. The risk of us injuring the colon is very, 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 very small. If you hear instances of injury to the bowel, it is usually either due to a big polyp that we remove. Sometimes if you remove a big polyp, we may injure the bowel. Or if the person who's doing it is not very careful or not very skillful. Okay, but if you find someone who's competent and experienced, the risk of colon injury during colonoscopy is almost negligible, very, very low risk. So don't be afraid. Okay, so colonoscopy is the gold standard. We will recommend that you do it from the age of 45 and just do it every 5 years for colon cancer screening as well as prevention of cancer. Okay, we move on to the next topic, which is stomach cancer. Stomach cancers used to be very high in incidence in the 1960s, and the incidence has dropped steeply over the last 30, 40 years. If you watch all those Cantonese shows, right, the black and white Cantonese shows, all the hero always die from stomach cancer. Because stomach cancer at that time was always the commonest cancer. Nowadays, stomach cancer, the incidence is much lower. Okay, the reason being partly smoking, partly the diet we eat. Okay, in the old days, if you take a lot of salted food, kiam he, kiam cai, and all this, preserved foods like canned foods and all these have a lot of chemicals called nitrates and nitrosamines, and these are actually carcinogenic for the stomach. They cause stomach cancer. The other things that cause stomach cancer, smoking, and this bacteria in the stomach called Helicobacter pylori, which we will talk a bit more about in a while. And if you're older, if you're male, if you're Chinese, or if you have a family history of stomach cancer, you also have a higher risk of stomach cancer. So look at this graph, it's quite interesting. Males in general have a higher risk compared to females, and Chinese have a much higher risk compared to Malays and Indians. So I see some of us here, Chinese males above the age of 50 has a relatively high risk of stomach cancer. So if you look at the population graph, you may think that stomach cancer is quite low risk compared to, say, colon cancer. But if you actually look at Chinese males, our risk is actually fairly high. Okay? Therefore, what do we recommend for screening of gastric cancer? If you have no symptoms, stomach cancer is actually not common enough for us to recommend you routine screening. Okay? But if you're Chinese male, or if you're aged more than 50, Chinese male, we would recommend that you come for screening. Or if you have a relative with stomach cancer, we also recommend that you come for gastric cancer screening. And the best way to do it is with like colon cancer, with a scope. With a scope, put the scope down, it takes 5 minutes, check the stomach, look for cancers, look for pre-cancer changes, and look for Helicobacter. So a lot of times, we also recommend that we do opportunistic screening, meaning if you come for colon cancer screening, you come for your colonoscopy, we will say, why don't you, by the way, also check your stomach? It's true. It takes only another 5 minutes. We put the scope, instead of on the bottom, we put it on the top, not the same scope, different scope. A smaller one, a smaller one. We put the smaller scope from the top, we look at. It takes another 5 minutes, you're already sedated, you're already sleeping, you won't even know. It costs a little bit more, to do both, but I think it's worth it. It's what we call opportunistic screening. So because Asians do have a significant risk of stomach cancer, but not enough for you to recommend you to come for screening by itself. But if you come for colon cancer screening, do your opportunistic screening as well. Okay, why? Because, this is how the screening process is. Same like the colon scope, but we put it from the top. So it takes about 10 minutes, 5 to 10 minutes. We give you some sedation together with the colon scope. Very safe, very comfortable. So this is what a gastroscopy will look like. Now, okay, the other, when we do the stomach scope, we not only check for cancers and early cancer in the stomach, we also take some biopsies of the stomach to look for this bacteria called Helicobacter. And Helicobacter is the important cause of stomach cancer. It is quite a common infection in Asia. In Indochina, it's very, very common. In China, it's also very, very common. In Singapore, it's fairly common. Maybe about 20% of our population may have Helicobacter. And Helicobacter is a very important cause of stomach cancer. It lives in the stomach. It causes chronic irritation in the stomach. Sometimes it gives you indigestion or discomfort. When you eat, you feel like 不消化, that kind of feeling, bloating and all that. Sometimes it doesn't even cause any symptoms. It just stays there. And when it stays there in the stomach, it causes chronic inflammation until the stomach glands start to look like intestinal glands, what we call intestinal metaplasia. And this is an important change in the stomach because it's a pre-cancer kind of transformation. It increases your risk of getting further changes that can lead to stomach cancer. So during the scope, we will not only just look, we will take biopsies to check for Helicobacter and also for intestinal metaplasia. Okay, if you suspect you have Helicobacter but you don't want to come for a scope or you don't need to come for a scope, you can also detect Helicobacter by other means. You can do a breath test. They will just take a breath sample. We can also do a stool sample, or you can also do a blood test. That can also detect Helicobacter. The important reason for detecting Helicobacter is if we treat your Helicobacter before it causes problems in the stomach, we can actually prevent stomach cancer. And it's true. In China, there are a number of very big studies that have shown that stomach cancer can be prevented by treating Helicobacter. In Singapore, we cannot do these kind of trials, but in China, you can. You just announce in the newspapers, everybody come, we pay you $400 to do one scope. Those who have Helicobacter, half we treat, half we don't treat. Helicobacter can be killed by a course of antibiotics, about 10 to 14 days of antibiotics. So all those they found to have Helicobacter, they will follow up. Those people who have treated on the one side, they find that after many years, the incidence of stomach cancer is much lower than those who have Helicobacter but they didn't treat. So these big studies have now been done in China, and we found that if you treat your Helicobacter at the early stage before it causes problems, you can prevent stomach cancer. Therefore, all our patients who have, I do a fair bit of stomach cancer surgery, and all the relatives of my patients, I will ask them to come for Helicobacter testing because we want to make sure that we eradicate one important risk factor for stomach cancer. So prevention strategy for stomach cancer, if you belong to a high-risk group, in other words, you're Chinese male, or if you have family history of stomach cancer, come and do your scope. Okay? And during the scope, we will check you for Helicobacter. If it's positive, we will treat you with antibiotics. And we also do biopsies to look for that pre-cancer change. Just now we talked about intestinal metaplasia. If you do have intestinal metaplasia, we will see whether you have high-risk intestinal metaplasia or low-risk type. If you have high-risk type, you need to come every year for a scope because once we start to see that your intestinal metaplasia has become dysplasia or early cancer, we can remove it with a scope without you even having to undergo surgery. Okay? So this is a strategy to help prevent stomach cancers. Now, a few words about liver cancer. Just now you saw in our graph that liver cancer is actually fairly common in Singapore as well. But the good news is it's not so easy to get liver cancer. Most of us who have normal liver will not get liver cancer. In order for you to get liver cancer, you need to have either a hepatitis B infection, that means you're a carrier of hepatitis B, or you're a carrier of hepatitis C, or you drink a lot of alcohol and your liver is already damaged by the alcohol. Okay? So if you don't have any of these, it's quite unlikely that you will get liver cancer. Example, if you're a hepatitis B carrier and you develop chronic hepatitis that leads to hardening of the liver called cirrhosis, your risk of getting liver cancer is very, very high. So for this group of people, if you are a carrier of hepatitis B, you need to come for a blood test every 3 months to 6 months. And you need to do a scan, an ultrasound, to look for a cancer change every 6 months to every year. Okay? For the rest of us who do not have a risk factor for liver cancer, there is no need to do a screening, but we do recommend that you come and check whether you have hepatitis B or C. If you don't, then you should get yourself vaccinated. In Singapore, there's now a strategy to vaccinate everybody, including everyone who is born. So they have this pregnant women, they were screened for hepatitis B, and the children are all immunized. So in the years to come, our risk of getting liver cancer will be much lower as a population. Okay? So if you do have if we find that you actually, we pick up that if you come for screening and we do a hepatitis B or C check, and you find that you're actually a carrier, then we would recommend that you do regular screening for ultrasound every 6 months to a year. And ultrasound can actually detect a cancer that is very, very small. Half a cm we can detect. And you should come for a blood test every 3 to 6 months to look for this tumor marker, a cancer marker called alpha-fetoprotein. Because once we find that your alpha-fetoprotein starts to rise, it indicates that there is a cancer change in your liver. Okay? Which brings us to our final next topic, which is cancer markers. A lot of people go to the GPs every year. They do a cancer marker test. They pay $200 to $300. After that, the doctor tells them you have no cancer because your cancer markers are all negative. They're very, very happy. Okay? So, but this is wrong. Okay, cancer markers should not be used in this way for screening because cancer markers are not accurate enough to detect cancer. It's not meant for screening. So you shouldn't be wasting your money and give yourself false reassurance. Because even though you have a cancer, your cancer marker may be negative. Okay, cancer markers, there are various types of cancer markers you can see here. And different markers are associated with different types of cancer. For example, CEA is associated with pancreatic cancer, colon cancer. Alpha-fetoprotein, we talked about it just now, is useful for liver cancer. But if you are a normal person, healthy, you should not go for all these cancer marker tests because it's meaningless. Cancer markers are very useful to the doctors for diagnosis, staging, and surveillance of disease, okay, but not as a screening for cancer, okay? In fact, the government wants to clamp down on all these cancer marker tests, which I think is reasonable because a lot of times, some people also have elevated cancer markers for not cancer reasons. Sometimes if you're a smoker, your CEA may be high also, you know? Or if you have gallstones or endometriosis, some of your cancer markers may be high. So a lot of people get very worried, go for extensive tests, and in the end, find that there's nothing. So cancer marker shouldn't be used in this way, okay? Which brings me to the next topic. Okay, we go through a few more cancers, the rest of the cancers we talked about just now. And we'll end off maybe in another 5 to 10 minutes. Okay, to round up, lung cancer, our ministry does not recommend chest X-ray or doing all this sputum tests and all that to detect cancer. And it does not recommend doing low-dose CT scan to detect or screen for lung cancer. Although, if you look at the American Cancer Society, they recommend that those people who smoke a lot, meaning more than 30 pack years. 1 pack year means if you smoke 1 pack for 1 year, it's 1 pack year. If you smoke 3 packs a day for 1 year, it's 3 pack years. Okay, so if you smoke 3 packs a day for 10 years, it's 30 pack years. Okay, understand? So if you smoke more than 30 pack years, and you are between the age of 55 to 74, you should come for an annual low-dose CT scan of the chest to look for, detect early lung cancer. Okay? Anyone taking photographs? That means you're more than 30 pack year guy. Okay. And you must still be smoking or you have quit within the last 15 years. Okay? That means 15 years, you quit 15 years ago, your risk is still there, So only when you pass the 15-year mark after quitting, your risk comes back to normal. Okay? Average risk people should not go for a routine CT scan because not worth the radiation. A lot of people go for, come for all these. A lot of our foreign tourists, medical tourists, they come and do all these extensive tests and all that. Even they have no risk factor. Okay, so that also not necessary. Next one, prostate cancer. Okay, for males, we talked about cancer marker. I forgot to mention, maybe the only cancer marker that may be useful for screening is PSA. PSA is what we call prostate-specific antigen. It's a marker of activity in the prostate gland. So if you have a prostate enlargement or inflammation in the prostate, the PSA can also be high. But if you have a tumor or cancer in the prostate, it can be high as well. Therefore, in some specialists recommend that you do PSA for screening for prostate cancer, but some of them don't because there's a lot of controversy. Because PSA can be elevated in normal conditions, benign conditions as well, it results in a lot of overdiagnosis and overtreatment. And prostate cancer is a very unique cancer in that it can remain a small cancer in your prostate gland for many years without causing any problems. So some of us, we are like 60s, 70s, you might actually develop a small cancer in the prostate gland. But if you live to your 90s, to your 100, and you die of heart disease, the cancer may not have bothered you for the last 20 years. But if you had done a PSA and it was high, you've gone for surgery, you've gone for radiation, you've gone for chemotherapy and all that, and it may not have affected your prognosis at all. So there's a lot of controversy. So sometimes treating these early cancers doesn't actually change your mortality at all. And some people have calculated and found that you have to treat 1,000 symptom-free guys who have cancer in order to save one additional life. Okay, so may not be worthwhile also, but our guidelines say that MOH guidelines say that there's lack of evidence to support population-based screening for detection of prostate cancer, but if you are between the age of 50 to 75, you may be offered screening after a discussion with your specialist or your GP or your doctor. You discuss the pros and cons, whether you want to screen or not. If you want to screen, you can do a PSA test every year, okay? Or every 2 years if you are low risk. Once you do a test, we found that your PSA is very, very low, you can do every 2 years, or you can do every year, or you cannot do at all. So a lot of controversies. But I'm not a urologist, so I'm not going to talk too much about these controversies. We move on to women. Okay, breast cancer is important for screening. So MOH guidelines, if you are above the age of 50 to 70, you should do a mammogram every 2 years. A mammogram is a simple X-ray. I think you all know, right? Where they compress your breast, take a few pictures of the breast, and look for calcifications or signs of early cancer in the breast. Okay. If you are between the age of if you're between the age of 40 to 49, it's optional. If you want to do screening, you should do it annually. Okay. So, but this one is also a little bit of controversy. So plus and minus, if you're between 40 to 49, whether you want to come for screening. But if you want to come for screening, you should do a mammogram every year. After you're 70 to 75, in Singapore, the women have a lower incidence of breast cancer. So screening mammography may be less beneficial and should be individualized, meaning discuss with your doctor whether it's necessary or not to do it. If you're less than 40, then you don't screen at all. In addition to this, we have some guidelines from our College of Radiologists. If you belong to a high-risk group, meaning you have a strong family of breast cancer or even ovarian cancers, especially if your relatives develop this cancer at a young age, or if you are found to have this BRCA gene in your family, then you should come for annual MRI screening. Okay, from the age of 25 to 30, you should start doing an MRI of the breast to look for early cancer. In young people, this age, it's not useful to do mammogram because the breasts tend to be very dense. It's not very useful to do an X-ray, so you do an MRI instead. But once you pass the age of 30, you can do a mammogram. Okay. Now, cervical cancer. Cervical cancer is usually caused by this virus called human papilloma virus. It is a sexually transmitted virus. So people who are sexually active at a young age may be exposed to this virus, and this virus can cause cervical cancer. So the screening for cervical cancer includes either doing a smear of the cells of the cervix, what we call a pap smear, or what we call co-testing, meaning do a pap smear as well as a human papilloma virus DNA testing. Okay? In our Ministry of Health guidelines, it says that from the age of 25, everyone should come and do a pap smear, okay? And if you, the interval should be every 3 years, and you stop doing at the age of 69, okay? Got it? Okay, so that's cervical cancer. Ovarian cancer, there's not very many ways to screen for ovarian cancer. The best way probably is doing the ultrasound of the pelvis to look at the uterus, the ovaries. Okay, so in our guidelines in the Ministry of Health, if you are average risk, screening is actually not recommended. Okay, and there's actually no effective method of routine screening of asymptomatic women who are at average risk for ovarian cancer. So screening is actually generally discouraged for ovarian cancer. Next, womb cancer or endometrial cancer. How to screen for this cancer is by doing an ultrasound, but not an ultrasound like a pelvic ultrasound like that, but a transvaginal ultrasound. That means they actually put the probe into your vagina and do an ultrasound from there. The reason being, pap smear is not sensitive for anything that's above the cervix, that means in the uterus. Okay? So our guidelines, Ministry of Health, do not screen women with average or increased risk for endometrial cancer. But if you have high risk, then you should be offered annual screening, okay, with transvaginal ultrasound and biopsies between the age of 30 to 35. Okay, I want to introduce another topic of screening. Maybe, do I have time? 2 more minutes. Okay, 2 more minutes, can. Actually, I was cheated. Last week took some time. Okay, something that is very new. We all think about cancer screening as doing all these tests to screen you for cancer. But one important aspect that is coming up in the recent years is actually, can we actually screen your genes for cancer? Okay, we all know that all cancers involve a change in the gene. You know, cancers are due to genetic changes, mutations. So mutations in your gene could lead to cancer. But some people may already have a genetic code that they have that they inherited from your father or your mother that predispose you to mutations that lead to cancer. Okay, so these are what we call cancer family genes. We won't go through that because we don't have much time. Okay, we won't go through that. Okay, if we talked about colon cancer just now, right? 90% of colon cancers are not due to cancer family genes. In fact, most people who have colon cancer do not have any family members with colon cancer. They say, why did it happen to me? I don't have any cancer, I don't have anyone in my family with colon cancer or any cancer. But the reason is why, I said just now, right? Accident, right? Accident can happen to anyone. But there are some people who are more prone to these accidents because it may be something that runs in the families. Either it runs in the family because of the type of food you eat, or your exposure to certain carcinogens like smoking. The father and the brother and all smoke, so everybody has a higher risk, or the type of food you eat, and some minor genetic risk. But there are 10% of colon cancers which are what we call hereditary, meaning you have inherited a gene that makes you very high risk for colon cancer. For example, in the general population, all of us, our risk of getting colon cancer is about 5 to 10%. Okay, 1 in 20. Okay, but if you've inherited this gene called Lynch Syndrome, your chance of getting colon cancer is almost 80%. If you inherited this gene, FAP gene, your chance of getting colon cancer is 100%, and you will get colon cancer before you're 25. In these people, by the time they reach 15, 16 years old, if you do a scope, they will find hundreds and thousands of polyps in the colon. And all these will eventually become cancerous. And this is actually a genetic risk. So people we know that have this gene, we will actually recommend prophylactic surgery. Prophylactic means prevention. Preventive surgery to remove the colon, the entire colon, even before they have a chance of getting colon cancer. So the question now is, instead of waiting for all these things to happen, I got almost like about BRCA. Do I? Okay. So now we can, instead of waiting for all these things to happen, we can actually test you for all these genes, because we already know these genes are inheritable genes that causes cancer. In the old days, for us to test these genes takes a lot of money. Okay, if you're very, very rich and you want to spend $1 million, you can test your gene for all these cancer genes. Okay, but not all of us can afford $1 million for a gene test. But now, the cost of doing all these gene tests have become lower and lower because of all these machines, which are highly effective. Look at this cost. Okay, at about 15 years ago, 15, 20 years ago, it cost about $1 million to do these gene tests. And in 2012, it cost about $10,000, 10,000 US dollars. Now, if you want to do the test and you ask me, I can do it for you special $3,000 Singapore dollars. Okay. Last year, if you ask me, it was 5,000. Okay, but now there are a lot of companies coming on. In fact, one of the companies that we work with, he's outside there. They do the gene test for about $3,000, and we send the test to Hong Kong, where we use the database from the Beijing Genomic Institute, which is a very large database of Asian-centric cancers. So we can actually tell you whether you have inherited any gene that causes cancer. Okay, about $3,000 now. Maybe next year you ask me, I can tell you it's much cheaper. So it's become actually affordable. It's not cheap, but it's affordable. Okay, so for example, colon cancers, we can test you for these genes. Breast cancer, breast cancer, we test you for this BRCA gene. I talked about it just now. BRCA gene is a very famous gene. Angelina Jolie tested herself. At that time, it cost $15,000. And she had BRCA gene. Her chance of getting breast cancer or ovarian cancer is very, very high, or 80, 90%. So she decided to go for double mastectomy, remove her ovaries for prevention of cancer. So if you have a strong family history, you suspect you might have all these things, you want to test, can. Okay? So these are some of the known genes that causes different types of cancer: pancreas cancer, breast cancer, ovarian cancer, colorectal cancer, thyroid cancer. So if you tell me, I've got so many members of my family with cancer, I don't even know what cancer I'm at risk for. Then I say, come and do the pao ka liao test. So we do one test that expanded. We test everything that we know for. Okay? So that costs about $3,000. If you want to do the focus one, like say colon cancer, then it costs less. Okay, so who should go for genetic testing? Not everybody, because it's a waste of money. But if you have many first-degree relatives or several first-degree relatives with the same type of cancer, you have cancers linked to a certain kind of pattern. We know like breast cancer, ovarian cancer, pancreas cancer are linked. So if certain pattern, or your family members have a cancer at a younger age, of funny types of cancers, you have multiple polyps in your family, then you might be a candidate for genetic testing. What about if you are very kiasu, you just want to know, can you do? Or if you tell me, I don't know my family history, I'm an orphan, or I've been adopted, or my dad ran away and we don't know what happened in his side of the family, and you're very worried. But it's true, right? All these situations happen, and you want to know, you got cancer phobia. Can you do these tests? The answer is yes, because it just involves a blood test. If you really want to spend your money, you can. There's no harm, right? But before you come for the test, we also want to do genetic counseling with you. We want to take your family history. We want to tell you what a positive test means, what a negative test means, so that you don't run away. You think you take your results, say all negative, I won't get cancer in my lifetime, then I smoke, eat, drink, whatever I want. Because most cancers don't occur because of genes, right? It still occur because of accidents. So you must still lead a healthy lifestyle. Don't think that you will not get cancer just because you don't have a cancer family gene. Okay? And if you do have a cancer family gene, you must know the implication of it. So we explain everything to you before we actually do the test. Some of them go back and think, say, they call back and say, Doc, I think I don't want to do, although I have a high family history, strong family history, I think I don't want to do. I'm worried once the result is positive. I keep thinking about it. I can't live with it. It's like having a time bomb. I cannot live with a time bomb. True? Yeah, for some people it's true, but we will tell them the advantage of knowing that you have a time bomb is I can tell you where the time bomb is. Okay? So if we test you positive for a certain gene, I can tell you that you will have to look very closely at your breast, your colon, or your pancreas, or whatever, and we will tell you exactly what tests you need to come at what intervals. So at least we can manage this risk. And if you have these genes, it means that your children will have a 50% chance of getting these genes. So the next thing to do is to buy insurance for your children and then get them tested as well. Because if they are tested positive, then they also need to be managed rather than wait for cancers to happen. So if you have a time bomb, better to know where the time bomb is, manage that risk, like Angelina Jolie. I think it's a very good example. Okay, I think I'm probably at the end already. Okay, conclusion, screening for cancer, easy, safe, and I promise you, right, may save your life. So if you take home the message and you come for screening and you do the right thing, I think hopefully 1 in 3 of you here, we hope to prevent some cancers. Thank you so much for your attention. Are we supposed to take questions? No.
Thank you, Dr. Luo. Okay, so does anyone have any questions?
Okay, this is our clinic, Pan Asia Clinic. Joycelyn in front here is our marketing manager. If you want to find out anything from her, you can ask her. She'll be outside. If you want to come for screening and all that, if you want to do it privately, you want to with us, you can do your inquiry. We can arrange for it.
So we actually have some questions on Slido.
Okay. Are all polyps cancerous? The answer is no. Polyp, as I explained to you, just means a growth in the colon or in the nose or in the wherever in the stomach. So a polyp can occur anywhere. Typically, polyps that occur in the stomach, in the nose, are not precancerous. In the colon, polyps may or may not be precancerous. Okay, there are some polyps like hyperplastic polyps, which are quite common, which are not precancerous. But what we call the tubular adenoma type of polyp are precancerous. Okay, so in order for us to recognize whether this polyp that we found in your colon is cancerous or not, precancerous or not, we have to take it out and look under the microscope. It's very difficult to tell the difference. Okay? Fatty liver, does it mean I'm more prone to liver cancer? No. Okay, but fatty liver can cause cirrhosis, and that can lead to liver failure. Okay, very rarely fatty liver, that cirrhosis due to fatty liver is associated with cancer.
So any more questions?
Yes. $65. 65 is very young now. No? Most of us say you stop screening at the age of 80. 75 to 80, we stop screening because, not because you won't get cancer, but because the benefit of screening become less. Okay, because we prevent colon cancer is the next 5 years, right? But more likely in the next 5 years, you might die of a heart attack or a stroke or something. So the benefit of doing a scope at that age may not be so high, not so great. Not that you won't get cancer anymore. But 65 is definitely, 60 definitely no. This is the prime time for cancer. You must do your intensive cancer screening, as what we have discussed. But of course, if you're talking about inherited cancers, usually inherited cancers come at an early age because you have a bad gene. So by the time you're 40, 50, you should have shown already. But if you're past 60, likely that you didn't inherit that gene, but you will still get cancers due to normal risks, okay? Also, because if you're older, like 80s and all this, when we start to do invasive testing and all that, there's a higher risk. Young people, the risk is very low, but if you're older, you're 80, 90, or 100 years old, giving the sedation and all that also got some risk. So we always balance the risk and the benefit. When the benefit is not so high, then we say, no point screening. But there are some 80-year-old, 90-year-old that excellent health. So we say, continue screening because you live to 110. Okay. Yes. Test for tumor. Yeah, cannot. Blood test can only test for cancer markers, which I already told you not useful at all. No use, because these are just markers. But having said that, in the future, maybe in the next 5 years, you can actually do a blood test and detect whether you have cancer genes, fragments of cancer genes in your body, what we call a liquid biopsy. In fact, there are some liquid biopsies now that are approved for lung cancer. That means we are using it to screen you for lung cancer or nose cancer. Do a blood test to detect whether you have any fragments of cancer genes in your bloodstream. In the future, that may come. That is actually the holy grail. A lot of companies are trying to get approval to do this liquid biopsy cancer screening. So if you know of any company that is close to getting approval for that, you should put all your money in that company. The profits will explode 100,000 times. Okay, any other question? Yes? Okay, that one is different. That one is, what was it for? It's for treatment of cancers at the genetic level. So molecular treatment of cancers. Cancer treatment. Yeah, sort of. Instead of killing all the cells with chemotherapy, they are targeting only the cancer cells at the molecular level, at the way the cancer replicates.
I understand that our body has cancer cells, right? And to everyone. When does these cancer cells activate?
No. We should not have cancer cells in all of us. Yeah. You mean all of us got cancer cells circulating? No. But mutations take place all the time. Genetic mutations take place in our cells all the time. So you get mutant cells forming all the time in your skin, in your colon, at the rapidly replicating areas, the lungs, the colon, all this. The mutations take place all the time, but usually these mutants are killed off. They are killed off by our body, what we call our immune cells. Our own immune cells will kill off all these bad cells. But certain mutants, they are not killed off by our normal cells, then they start to grow and form a colony of mutants. And these colony of mutants are not cancer yet, but they may be pre-cancer. After several mutations, then they become more and more super mutant, then they become cancer. But it's not true that we have cancer cells circulating all the time. No. Bacteria can cause cancer. There's only one bacteria known to cause cancer in man. We discussed it just now. Helicobacter pylori. It's a bacteria, only one that causes cancer in humans, stomach cancer. But certain viruses do cause cancer, and we also discussed it. The human papilloma virus causes cervical cancer. Hepatitis B and hepatitis C virus cause liver cancer.
Okay, so those are all the questions we have time for today. Thank you, Dr. Luke. We have a token of appreciation for you.
Thank you for your time. I hope you learned something, and I think got tea, right?
Yes, so it's time for tea break now. You can go out and get your refreshments. Can everyone be back by 3:30? Thank you.